Good morning, everybody. So today what we'll do is we'll go through something will be a broad sort of overview on the more common complications that we see post-pelvic radiation therapy in urology. And I think this is an important topic because as urologists, we're often are the ones that are seeing these patients with their complications many years often after the initial treatment. And also because I think from the prostate cancer perspective, we're often the ones that are first counseling patients on different treatment modalities. And having a bit of an overview of the complications of radiation therapy, I think, is important in counseling patients thereafter. So what we'll talk about today is we'll go through the impact of radiation therapy on normal genitourinary tissues and hopefully use that to go through some of the more common complications that we see post-radiation therapy, focusing on radiation cystitis and acute lower urinary tract symptoms post-radiation. We'll talk a little bit about urethral stricture disease, we'll talk about erectile dysfunction, and briefly touch on secondary malignancies post-radiation. So the role of radiation has really expanded quite dramatically for pelvic malignancies over the past few decades. And we see that there's a role for radiation in almost virtually all pelvic malignancies with curative intent. So for colorectal cancer, we see a role for neoadjuvant chemoradiation. In gynecology, oncology, there's a role for curative intent radiation for cervical cancer. And of course in urology, prostate is really the cornerstone of pelvic radiation therapy. And we see a role for brachytherapy external beam. We see a role for radiation for PSA recurrence after radical prostatectomy. And now more so perhaps for slow volume metastatic disease with recent clinical trials that are coming down the pipeline. But I think this all means is that we'll see likely more and more radiation-induced complications coming in down the road as radiation is more and more taken up for the treatment of these malignancies. Here's some data from the US looking at the utilization of radiation for curative intent for localized prostate cancer. And what we see is consistently across the board, about 20 to 25% of men in the US are opting for upfront radiation, external beam, or brachytherapy. So with time, that number has stayed consistent. I think we will be seeing more and more of these patients develop complications post-radiation. If we go through some of the different approaches to radiation therapy, and these are quite familiar to us because of prostate and how both are appropriate treatments for prostate cancer. The more common form of radiation that we're exposed to is external beam, where patients go and get external treatment with a generator for radiation is external. And usually what we'll see is a total dose prescribed and a total number of fractions over which the radiation is prescribed. So for prostate cancer, usually that's about 70 to 80 gray given over 30 to 45 fractions. The second form is brachytherapy, where we can see either a high-dose brachy given, where the implants are actually left in situ for an hour or two and then removed, and that's given over a couple of treatments, or the more standard low-dose brachytherapy, where the seeds are actually left in situ thereafter from treatment. And we can often see these two treatments actually combined, so brachy and external being given together, especially for more high-risk disease. The impact of radiation therapy, of course, is very good when we look at the acute phase for treatment of cancer. There's lots of good impact on the actual cancer. We see that radiation causes direct DNA-induced damage. It causes induction of reactive oxygen species that are directly toxic to the cancer. And because we get that initial tissue injury to the cancer, there is also an upregulation of inflammation and perhaps antitumoral immune response as well, which contributes to that initial early effect, which is what we look for and what we see for the efficacy of radiation in oncology. Of course, the short-term effect is actually more or less worrisome for us. It's often self-limited and really will resolve over the next 3 months post-treatment. What's more worrisome for urology is kind of the late biological effects of radiation, which manifest in the months to years post-treatment. What we see here is kind of a perpetual response to the radiation from the radiated tissue, where we get a vasculopathy where there's endarteritis, inflammation of the blood vessels perfusing the irradiated tissue, that then cause chronic ischemia. As a result, we see an abnormal wound healing response, where instead of regeneration of normal tissues, we get infiltration of myofibroblasts that lay dense collagen. And this cycle tends to perpetuate itself because the ongoing ischemic insult tends to be persistent for years to come. So if we simplify that figure up there, this figure over here is showing skin as an example. But if we compare radiation-induced injury to just the normal injury, post-trauma, normal injury, we get inflammation, we see proliferation, and then resolution of that initial injury with hopefully resolution and repletion of normal tissue. But here, we get that vasculopathy, which causes ischemia and leads to fibrosis. And because that ischemia is still persistent, patients can often end up in this sort of loop where ischemia and fibrosis play off one another. A proportion will go down to resolution, but the ones we tend to see with complications are stuck often in this perpetual cycle. What this looks like for us is some pretty kind of gnarly looking images where we can see up here we have radionecrosis of the prostate. Here right next to it we have an obliterative dense stricture which causes urinary retention. And here we have an image from cysto from radiation cystitis where we get abnormal blood vessels forming which causes recurrent radiation-related bleeding. To summarize the different impacts of radiation that we see in the early phase, which is kind of less than 3 months out from radiation treatment, we see toxicity due to acute inflammation and radiation-induced damage, which tends to cause cystitis and also urinary retention, perhaps due to inflammation of the urethra. And in the long run, over 6 months out from treatment, we get a process driven by vasculopathy, fibrosis, which causes stigmata like stricture, fistulas, hematuria, and erectile dysfunction. Before we dive into these different toxicities in more detail, how prevalent is this problem? And this is a recent study that was done actually out in Melbourne, Australia, where a tertiary care center looked at their patient admissions both through the emerge and also electively over 6 months. And they found that about 1% of their elective admissions was attributed to radiation-induced complications and 7% of emergency department complications. About half of those were due to radiation cystitis, 30% due to stricture disease. And for me, this was a pretty significant number. And for the patients actually who were admitted, the mean lengths of stay were around 7 days. So it tells me that these patients were not in for straightforward complications. They were admitted for prolonged periods of time. So going forward, I kind of like to look at the different toxicities based on the different urologic structures, starting with the bladder. And from the bladder, if we kind of look at the different phases of bladder toxicity post-radiation, starting from the initial treatment here, in the acute phase, we have that direct destruction of the urothelium, which can lead to loss of the glycosaminoglycan layer, and lead to some extravasation of urine underneath to the layers below, and perpetuate an inflammation and cystitis sort of picture. Over time, that will often resolve, and I'll show you some data in regards to this thereafter. And we enter into a latent phase where the chronic fibrosis and ischemia starts to manifest. And patients in this kind of limbo period will be asymptomatic until we get a more significant degree of fibrosis and vasculopathy, which manifests with the classic picture of chronic radiation cystitis that comes to mind, with bleeding and also severely scarred and low-capacity bladders with significant storage-related symptoms. We go into the acute phase. This is probably the most common side effect post-radiation therapy. And about 50% of patients will get, we say, grade 1 to 2 cystitis based on the scale down below, which is based on the radiation therapy group, radiation or free urinary frequency. That's not worse than Q1 hour, and dysuria perhaps requiring some medication like pyridium. only about 5% will go on to have grade 3 or more, which is actually not too bad. And if we look at the natural history of this, about 95% of cases will have spontaneous resolution by about the 3-month mark. And often they'll require just a bit of temporization with anticholinergics, mirabegron, or pyridium. The risk factors for worsening lower urinary tract symptoms are directly related to the dose of radiation that's given, as you would expect. If patients have baseline lower urinary tract symptoms to start with, they're more likely to have exacerbation of this post-radiation. And brachytherapy as well tends to be associated with more lower urinary tract symptoms that we'll look at here. So post-brachy, we tend to see more men get acute lower urinary tract symptoms, and a certain proportion, about 10 to 15%, will get acute urinary retention post-brachytherapy. And this is urinary retention that's felt to be due to just edema within the prostate, secondary to the initial instrumentation. And it itself as well is self-limited. And we'll see again, 95% of men have resolution of this, just if temporized with CIC or catheterization. And here we have IPSS scores down below, actually from Juanita Crook, I think now is based at the Cancer Agency, looking at how that behaves post-brachytherapy. And we see that there tends to be a flare-up within the first few months post-radiation. But then thereafter, it actually settles to less than below the baseline, which tells me that perhaps some men get some relief in this period due to gland shrinkage post-brachytherapy. Of course, these obstructive lower urinary tract symptoms can be a bit problematic, and there will be a small percentage of men who are going to be quite bothered by this after brachytherapy. And the next logical toolkit for men who don't want clean intermittent catheterization is going to be a TURP. And this is something that I think should be exercised with caution, because there's a lot of data out there looking at retrospective outcomes post-TURP in the brachytherapy setting, where up to 25% of men will actually develop incontinence post-TURP in the post-brachytherapy setting. So I think what this goes to show is that going ahead with the TURP should be done cautiously, and if we go ahead with TURP for post-brachytherapy retention, it should be a very limited resection, if we even go down that pathway.
What percentage of acute patients go under TURP?
Don't know off the top of my head, but it's going to be a relatively small proportion, because the incidence of retention is only about 10 to 15%. For this particular study, I can't recall the total numbers that actually went on to get a TURP. Oh, actually, I have it down here. 3%. Just in my notes on that study. In the long run, short run, if we look at those outcomes, things actually are not too bad. It's more the chronic radiation cystitis that's a concern, where the chronic vascular changes to the bladder, that chronic ischemia causes sloughing of the urothelium and abnormal telangiectasias of the bladder that we can see down here on cysto. And this causes, or can cause, a pretty significant remitting gross hematuria. And we see this gross hematuria in about 5 to 10% of patients post all forms of pelvic radiation therapy. And the bleeding really falls along a spectrum, where we can get patients who have intermittent, relapsing, remitting bleeding to actual life-threatening gross hematuria where patients become transfusion dependent. In addition to the gross hematuria, we can also see a recurrence of progressive storage symptoms related to bladder fibrosis and significantly poor capacity for the bladder. For the urologist, the gross hematuria is really the more concerning aspect, because they can be very difficult to treat, and there really is not a lot of good evidence to guide the treatment of gross hematuria secondary to radiation. And recently, I know the CUAJ put out a best practice report, but really that's just summarizing small case series looking at this. The bottom line from that best practice report is we should follow kind of a stepwise approach, a damage control approach with the principle of doing the least harm that we can. The initial step for management of radiation cystitis is CBI if required, IV oral hydration, and perhaps cystoscopy with a bladder fulguration if need be. Thereafter, we move on to second-line treatments, which are intravesical agents like alum and formalin. These, again, do show some success, in 60 to 70% reported improvement in gross hematuria. And these are from small case series, though. It's only about 20 patients to 30 patients in each one. If patients are refractory to this step of treatment, then we're kind of moving to the more invasive side of things, which is looking at surgery with urinary diversion or cystectomy. But this is really something that should be reserved for the very terrible cases. And cystectomy in this setting. Yes, Miles?
So sorry, just like the stepwise for step 2, you know, I haven't found good evidence for like how long you run alum for.
Yeah.
Or if you give formalin multiple times before stepping up to embolization.
Yeah.
Did you see anything about that?
You know, not really. And I agree with you. Like, based on formalin, what we know is the success rates are pretty similar if we use, say, 1% versus 10%. 5%, and with the higher percentages, we get more bladder scarring afterwards, and more lower urinary tract symptoms. So, again, it's not an area where there's a lot of evidence to really guide anything. And really, this is just based off of case series. It's like, okay, this kind of works. We can try it. The big step to therapy that I want to talk about, so on the next slide, is hyperbaric. But I'll get to there on the next slide. Really, for diversion, though, that's something that carries a very high complication rate. Actually, mortality is as high as about 15% in the setting of these patients, where often they're quite frail due to significant anemia, and also the surgery itself is complicated due to obliterated tissue planes. If we go on to the treatment that I think holds the best promise for radiation cystitis, is actually hyperbaric oxygen treatment. And this is something where I think from personal experience, I think is really underplayed for the benefits to radiation cystitis. This is where patients go into this pressurized oxygen chamber, and they go in for dives for a few hours in there and breathe in 100% pressurized oxygen. And this treatment is actually felt to go to to get to the root cause of radiation cystitis, where improving the partial pressure of oxygen that reaches the bladder will hopefully reverse that ischemic insult that drives the bleeding and drives the ongoing fibrosis in radiation cystitis. The response rates to this are actually reasonably good, between 70 to 90% depending on the series. And there is data that, if started early, about 96% of patients will avoid progression of the radiation cystitis by the 1-year mark. So I think this is a treatment that should be at least offered to all patients at least in all stages of the radiation cystitis, because I think it can really delay progression and really comes with minimal risk, apart from maybe mild sinus or ear barotrauma.
Are you going to go through any of the data on this? Because I always find that the data is from highly selective retrospective series. And
Yeah.
I'm not aware of any prospective data. And so I'm interested in your statement, you know, this holds the most promise and is underused.
Yeah.
But I just have never seen data that's all that robust.
Yeah, and really none of the data is very robust for any of the treatments. It's all retrospective based data. I think the reason why it holds the most promise is because the toxicity profile of this treatment is a lot better than a lot of the other intravesical agents that we used. It's getting to the root cause, or at least hopefully trying to get to the root cause of the radiation cystitis.
But the root cause is hypoxia.
Yeah.
Giving a treatment once a week forces a bit of a transient molecule called oxygen into the hypoxic region, but then of course it goes back to the hypoxic region.
Yeah.
But again,
Yeah, that's what I.
For 8 to 12 weeks. Not only is it data all retrospective, there's almost no comparative. See, like,
Yeah.
take this here and say 96% no
Mhm.
Actually, a lot of the time we're investigating.
Yeah. And I know one of the series, although it was quite small, like only about 57 patients, they showed that at the 5-year mark, most of these patients do relapse, about 50% of them. So I'm not surprised, but I think if we get these patients to at least not progressing for 5 years with minimal to no toxicity, I think it's a worthwhile treatment.
Do they accept them here at VG treatment?
They do accept them. There is a bit of pushback to getting them in because they argue that hyperbaric treatment doesn't get them out of trouble in the acute phase of the condition. But I still think it's worthwhile to get them in sooner because a lot of our patients are transfusion dependent with the hyperbaric oxygen, and it is a life-threatening condition. I mean, they obviously have one chamber and they're competing against patients with chronic wounds, patients at risk of losing limbs. But our patients who have this are, for the most part, very active patients, otherwise healthy. I think they should be made a priority, despite the pushback that we get.
They're keen to do it. They just don't. They're not excited about the patients on the ward with CBI going,
Mhm.
talking, transfusion getting ready. It's probably not going to make a difference in short term.
It's about 3 to 4 months getting into that master
Yeah, I think it's a appropriate hypothesis that needs testing.
Mm-hmm.
And if any resident wants to draft up a protocol, and it is something that would be testable.
Urologists would be happy to send us on their way.
Send it back.
At least for Kavanaugh wants to try.
Yeah. He's not here. He falls on.
It can also be done privately as well. There's clinics that have Hyperbaric, things like Penile Prosthesis. Some of it is heavy insurance.
The extended health insurance will actually cover it. Interesting. Alright.
Basically, we're trying to
So, overall, I know I didn't go through some of the specific trials looking at it, but a lot of them are quite similar, really just retrospective data. For the interest of time, I'm going to move on to other complications. Before moving on, just to wrap up, most of the acute bladder-related toxicity post-radiation is self-limited and will resolve within 3 months to a year. Urinary retention post-brachytherapy also will resolve in most cases with intermittent catheterization. And chronic radiation cystitis is probably the most difficult to treat bladder-related complication with progressive and remitting gross hematuria, with minimal evidence to really guide a logical approach to treatment.
The other thing that I can take home there that's practical is get the catheter as soon as possible. So many people, with minimal hematuria still on the catheter, and that's inducing a lot of irritation.
Yeah.
As long as it's in there, you're exacerbating the vicious.
Mm-hmm. It's interesting because some studies actually list catheterization as a treatment. Some of the review articles I came across, which didn't really make sense to me. I think it's probably better to get it out if not needed. So, moving on to the urethra. Looking at urethral toxicity, the major stigmata here is stricture disease. And this, again, is caused by radiation, I think, setting up really the perfect storm for strictures to form in the urethra. Because here we get that ongoing ischemia, which drives scarring in the urethra, and ongoing fibrosis and infiltration of fibroblasts, and also breakdown of the actual urethral smooth muscle, which can cause urine extravasation and lead to very dense, often long strictures that are located in difficult to treat areas close to the urethral sphincter. If we look at what some of these strictures look like, here we can see kind of a bulbar membranous urethral stricture with sloughing of the prostatic urethra, which often corresponds to that classic image of radionecrosis in the prostatic urethra. And these are typically seen post-brachytherapy. And here next door we have the more classic external beam stricture, which tends to be shorter bulbar membranous stricture And here beside it, we have an example of a more dense bulbar membranous stricture that's obliterative. So these strictures are indeed challenging. They occur, based on epidemiologic data, probably in about 5 to 15% of patients, around 10-year follow-up. And it's difficult to quantify what the incidence is, as it will often take many years of follow-up before these patients start to surface. We're really only picking up on patients that need an intervention for their stricture disease, are symptomatic, and probably lots of other patients are brewing strictures but are not symptomatic. And we may see them emerge at time points beyond the follow-up period for these studies. Most of these strictures tend to involve the bulbar membranous urethra and are located quite close to the urethral sphincter, which makes the treatment a bit challenging. And the factors that place patients at risk, like we'd expect if they've had previous prostate surgery, like a TURP or a radical P, they're more likely to get strictures that are more complicated to treat. Brachytherapy strictures tend to be longer and tend to be more dense. And other comorbidities like hypertension and diabetes also place patients at higher risk for developing strictures. Here we have a retrospective series of about 2,000 patients that was done in Michigan looking at the time course for urethral stricture disease. And here they're looking at freedom from what they called grade 3 urethral strictures, which means patients that are severely bothered by their stricture disease. And they show a pretty nice dose-dependent effect like we'd expect. We see that patients who, comparatively patients who got high-dose external beam, high-dose brachy, and high-dose external beam, and high-dose brachy, the patients that got more radiation were much more likely to get strictures going forward. Most of their strictures tend to declare themselves at about the 5-year mark here. And here we see it kind of leveling off thereafter, but I don't know how reliable their data is after the 5-year mark because the median follow-up was only about 6 years, and there's a fair bit of censoring thereafter. So I think their incidence is probably underestimated, and like we'd expect, we'd probably see more patients that they're missing would manifest with strictures more along this time point here. The management of these strictures, again, is a challenge. The first-line treatment is endoscopic management, usually with dilation, but DVIU can be considered, followed by ideally a course of CIC if the patient is agreeable to self-dilate and self-calibrate the urethra and keep it patent. The success rates of endoscopic management is really going to be variable, and I'll be honest, there's not a lot of good data on the success rates of endoscopic management because most of these studies are excluding patients who've had radiation-induced strictures, looking at DVIU or dilation. But if we apply what we know from traumatic strictures, the success rate will likely depend on where the stricture is located, how long it is, and the degree of fibrosis. Based on my estimate, if we look at studies which are examining recurrence rates of strictures for traumatic urethral strictures post-dilation DVIU, a lot of studies are quoting about 50% recurrence rates by a 1-year mark, 30 to 50%. So I think it's safe to say that the estimated success rates for radiation-induced stricture are likely going to be less than that. Furthermore, even though we attempt endoscopic management with the understanding there's a good chance of failure, repeat attempts at endoscopic management will risk the stricture getting more complicated for subsequent reconstruction. They can put patients at risk for incontinence, especially if the stricture is near the sphincter, and also fistula disease with more aggressive DVIU. So this puts urologists really between a rock and a hard place when it comes to looking after these strictures. There are some works trying to look at interventions that may help limit the morbidity from radiation-induced strictures for endoscopic management. And one approach that's been studied is to try and inject Mitomycin C at the site of DVIU with the hope that this will prevent urethral fibrosis from ongoing radiation-induced damage. And again, the series are small. This is a more recent one from 2017 with 18 patients who underwent DVIU for bulbar membranous strictures. And what the authors did is after performing DVIU in a radial fashion, they injected Mitomycin C at each injection site, or at each incision site, and then followed patients up with 1 month of daily CIC. Now, 1 year, they quoted the patients were 67% of patients were free from further endoscopic interventions at 1 year, and there was a significant reduction in the post-void residual after DVIU and mitomycin. But again, it's a very small series, and we're not comparing this to no mitomycin, so it makes any conclusions on this treatment difficult to really take forth.
Hypothesis on why that would work.
The Mitomycin C, the thinking is that if it's ongoing fibroblast proliferation, that's causing scarring and deposition of collagen, which is causing rapid recurrence of the radiation-induced strictures. The thought is that the Mitomycin C may halt that and be directly toxic to the fibroblasts. That's my understanding of the hypothesis behind why they consider giving mitomycin.
Makes no sense. Mitomycin is an incredibly fibrotic immune damaging agent.
It seems kind of like the urologist is familiar with this.
Yeah.
They may as well have been injected Cipro. Just
You know,
Flawed. It would be polite.
you know,
I mean,
you
there's-
make a
yeah.
perforation in the bladder, and really, really bad if you do that.
Yeah.
Perforate the urethra, and
they inject mitomycin, that's true.
interesting.
I mean, their success rate wasn't bad. I mean, in short-term follow-up, and it's small patient series, but
Only a third of them died.
You don't want to get your urethra. 50% out of your urethra.
so again, overall not great. Not really much to offer these patients in the endoscopic realm. Really, for the patient that's quite bothered and keen to look at definitive treatment of their stricture, we really have to move towards reconstruction. And the decision tree for reconstruction, and in my mind I kind of tried to simplify it, is looking at 3 questions. Is this patient going to be medically and oncologically fit for reconstruction? Are they going to be able to survive that surgery? Are they going to be around from a cancer perspective to reap in those benefits? Is their bladder severely crippled post-radiation? So if we repair their stricture disease, are they going to be debilitated by storage-related symptoms and not likely to have a significant improvement in quality of life after reconstruction? And does their urethra look like it has a reasonable chance of healing after reconstruction? So is it very calcified? Is it necrotic? So look at this approach to reconstruction that I kind of tried to formulate in my head to come to terms with the different options. All patients who are keen to go down reconstruction should receive urethral rest with 3 to 4 months of suprapubic catheterization. And based on narrative reports, only about 50% of patients who go down this pathway will actually kind of exit the flowchart here and will be okay with a chronic suprapubic once they realize it's not so bad. And this is a perfectly reasonable treatment option for these patients. The next step in the decision tree, if the patient still wants to go down the reconstructive path, is to look at the bladder capacity. If patients are quite debilitated by their having a small bladder capacity or severe pain or dysuria related to radiation cystitis, sometimes these patients may be best served to go down the cystectomy route if they have that severe radiation cystitis. If patients do not have that severe pain but have limited bladder capacity, then going ahead with a continent catheterizable stoma may be best serving them, plus or minus a bladder augment. If their bladder capacity is okay, then we can look at more urethral reconstruction. The ideal scenario is that it's a short stricture, less than 2 centimeters, and these patients can undergo an EPA, which is an excision and primary anastomosis, much like a simple urethroplasty. And the outcomes actually are not too bad following this intervention. If the stricture becomes more complicated, like it involves a prostatic urethra, they may actually benefit from salvage radical prostatectomy, dissection of the urethra, and a pull-through with a urethral sphincter, with the plans for a delayed artificial urinary sphincter. The worst case scenario is a devastated urethra where the bladder outlet is just completely necrotic and calcified, and these patients, again, should be counseled on going ahead with bladder augment, closure of the bladder neck, and a continent catheterizable stoma. If we look at data for just simple excision and primary anastomosis for radiation-induced strictures, success rates are actually not too bad, quoted about 70% at about 3.5-year follow-up. This comes at the expense of de novo incontinence at about 20% and possible de novo erectile dysfunction. And this data is reasonably consistent across the board, although we have to keep in mind that we're looking at kind of the best case scenario for a radiation-induced stricture undergoing reconstruction. Yes.
It's not even realistic for reconstruction radiation stricture.
I know, and this is, I don't know how much I really believe this, because I think these are highly selected patients. Like here we're looking at the best case, less than 2 centimeters. If the urologist kind of went in surgically and realized that, the patient may not be a candidate for primary urethroplasty, other than any other form of reconstruction, those patients are not included in this set. So,
this erectile dysfunction and non-radiation stricture analysis.
yeah, I know failure rates for traumatic stricture is about 15% at the 5-year mark, but thereafter they're good. I don't know exactly off the top of my head what the erectile dysfunction rates are for a traumatic stricture that undergoes urethroplasty.
It's like 50%.
About 50%? Yeah. Yeah. So it's actually not too bad in the broad scheme of things. And if we look at the devastated urethra here, data is quite limited in this setting. It's really maybe series of 1 to 2 patients. Often they're lumped in with radical prostatectomy-induced bladder neck contractures or any other form of really devastated urethra. So it's hard to say what the outcomes for these patients look like. But types of reconstruction that these patients would often undergo, an example of this is shown below here, where they undergo salvage radical prostatectomy and augment with the cecum, and then close off the bladder outlet, and then to bring up the appendix for an appendicovesicostomy. So my take-home points for urethral stricture disease is that it can be one of the more devastating complications post-radiation therapy. It can show itself many, many years after the fact. Endoscopic management is the first line, followed by CIC, but with the caveat that it's very highly likely to fail. A primary urethroplasty in the appropriate patient and the appropriate stricture has a reasonable success rate. But again, we have to be cautious about how to interpret the data. The last toxicity that I wanted to look at is erectile dysfunction, which is a very important one for patients, especially those who are contemplating treatment for localized prostate cancer. The classic understanding of radiation-induced erectile dysfunction is a slower onset progressive form of erectile dysfunction. The mechanism of this is not completely clear, but it's likely multifactorial due to direct nervous damage from the radiation, decreased perfusion due to vascular fibrosis in the corpora, and possibly corporal smooth muscle atrophy. And interestingly, there was a recent basic science paper where a group randomized rats to a single fraction of 22 grays, prostate radiation or sham, and they looked at erectile function after the fact, 10 weeks post-treatment, and looked at neuronal apoptosis after the fact. And they showed that at the 10-week mark, actually, based on cavernous nerve stimulation, there's no difference in erectile function at the 10-week mark post-radiation. But when they took neurons from the pelvic ganglia and cultured them, there's significantly more neuronal apoptosis and decreased dendrite formation in these pelvic ganglia nerves, which is in keeping with our understanding of radiation-induced erectile dysfunction, where the erectile dysfunction tends to manifest in a more delayed fashion. What does the data look like clinically? It's a challenging group to look at because of variable reporting different scales, different approaches to reporting erectile dysfunction, different radiation regimens, and the use of androgen deprivation therapy neoadjuvantly also confounds this. Based on the different studies I looked at, I think it's fair to say that the rates of post-radiation erectile dysfunction range anywhere from 30 to 60%. Again, depending on the above factors up top, and I'll show some data in regards to this. Over here, we have a Danish study which looked at incidence of de novo erectile dysfunction in patients who had self-reported good erections prior to treatment. And they're quoting for standard external beam about 30 to 40% incidence of erectile dysfunction that's self-reported at the 3-year mark. I think some better data on erectile dysfunction comes from the PROTECT trial, which looked at 1,600 men and randomized them to surveillance, radical prostatectomy, and external beam radiation with androgen deprivation. And they looked at standardized tools with the EPIC questionnaire and looked at 6-year functional outcomes. What we see here, again, I wouldn't look at the radical prostatectomy group or the surveillance group, but looking at the radiation group, we see there's a sharp decline in the first 6 months, which is likely due to androgen deprivation therapy, an improvement, and thereafter a slowish decline over the next 6 years. I think looking at their surveillance group, and I say, well, radiation surveillance did pretty well, but the surveillance group, 50% of patients got some form of treatment, so I think it's not really reasonable to compare those two. Post brachytherapy rates are about 50% overall. We see it's very variable though, depending on patient factors. So looking at their age, erectile function post-treatment can be high as 80%, the 10-year mark. Whether or not they got ADT significantly impacts this, and of course their pre-treatment function and their dose. Can we limit radiation-induced erectile dysfunction? This was a study that looked at low-dose Cialis and one randomized patients of that or placebo, the 1-year mark, and it looks like there really wasn't much difference, although in this study the initial decline in erectile function actually wasn't that much post-external beam or brachytherapy. The last point I wanted to make is for post-radiation erectile dysfunction is that a lot of patients who are quite bothered by this will follow the usual treatment pathway for erectile dysfunction, and some will go on to intracavernosal injections, and some may even go on to penile prosthesis therapy. Retrospective series looking at penile prostheses for the 3-piece implant comment that they haven't noted any increased rates of complications, and they quote a 15% revision rate at 4 years. It's reasonably standard, and no evidence of any erosion of the components or herniation. It is something interesting for urologists treating this complication. So the last complication I wanted to briefly touch on, really just for one slide, is secondary malignancy post-radiation therapy. And this, again, if we look at it, for prostate, which is probably more relevant to us in the urology field, there are some studies looking at the SEER database in the States, which is kind of a large database looking at about 70,000 plus patients. Some studies have shown that there is a significant increase in the incidence of secondary malignancy, quoting a relative risk about 34% compared to radical prostatectomy. But again, the absolute risk that was increased was quite small, about 6%, and this finding hasn't been consistently reproduced by other studies. But I do think, though, that secondary malignancy post-radiation is certainly a real phenomenon, and if you look at cervical cancer, where often the patients are much younger and have longer follow-up periods of time, some of these studies looking at these patients in similar databases quote an absolute risk of 22%. For secondary malignancy over 40 years of follow-up. So I do think this is a real risk, but in the prostate setting, it's probably not, we don't see as high numbers because we don't have as many years of follow-up to look at these patients. So overall, that's sort of whirlwind tour on urologic complications post-radiation. And this again, I wanted to just reiterate, this is just a subset of complications that we looked at. There are multiple other ones, like gastrointestinal toxicity, that we did not discuss. We didn't look at radiation-induced fistula disease. We didn't look at osteitis and bone-related complications. And we also didn't touch on ureteric strictures as well, which can occur post-radiation therapy. So, to wrap up, hopefully at the end of this talk, convince you that pelvic radiation therapy puts patients at risk for several potentially debilitating urologic complications that have no easy solutions for the treatment. Although the incidence of these different toxicities for each one ranges between 5 to 10%, depending on the nature of the treatment and patient baseline factors. If we add these different incidences for the different toxicity level, it can amount to the significant risk for a debilitating consequence for a patient post-radiation treatment, especially over longer-term follow-up. I think the numbers of these patients are likely going to rise, especially as oncologic outcomes continue to improve, especially as radiation therapy continues to be adopted more and more for the management of pelvic malignancies. And knowledge around of these post-radiation complications is critical to not only manage these patients, but hopefully counsel them on appropriate treatment options in patients, especially for prostate cancer, who are debating different treatment modalities for localized disease with curative intent. So with that, I'd like to thank everybody for your attention and your time. I'd like to also thank Dr. Cavanaugh for mentoring me through this, and I'll take any questions. Thank you.